please do.
Good evening. My name is James Cashman. I'm an orthopaedic surgeon in the National Orthopaedic Hospital Cappagh, and I'm delighted to talk to you this evening about hip pain in the young adult. Now, as you know, hip pathology can present from any age, from birth until old age. And as orthopaedic surgeons, we can do a variety of different interventions which can improve the hip, improve hip pain, and hopefully lead to better quality of life. What we do depends on what stage of life the patient is at. So obviously the operation you do in a child is different to the operation you do in an adult. And but you might ask, what's the point of it? As you know, hip replacement is a very successful operation. It generally has a low complication rate and it provides an excellent pain relief. Length of stay is 2 to 3 days. In some patients, they go home on the same day. And in terms of survivorship, they do great. You know, they last 100% of in certain patient populations, but as they get younger, maybe the survivorship isn't quite as long, with hip replacement in those under the age of 40 only lasting 67% of the time, up to 25 years. However, not all operations are successful, and you may be aware of the metal on metal ASR recall that took place around 2010, 2011, and the associated problems with it. And also, when you do joint replacements, usually the primary operation is successful, but as they fail, the subsequent treatments become more complicated, and subsequent operations maybe don't have the same success rate as the initial operation. The other thing to be aware of is not all hips are the same. This is a patient with left-sided hip pain, and they have a very subtle abnormality on the left hip with beaking of their acetabular labrum, maybe in keeping with ossification of that labrum, but otherwise it's a pretty benign looking x-ray. And in this x-ray, they have a different type of deformity, but this could be a completely painless hip on the left-hand side, even though it has a deformity typical of Perthes disease. And similarly, this is a normal hip for somebody who has a condition such as multiple epiphyseal dysplasia. And each of these hips provide different challenges. Just to remind you on the anatomy of the hip, well, the hip is a joint made between the femur and the pelvis. The femoral head articulates with the acetabular cartilage, and it's quite a constrained joint with the ball sitting nicely in the socket. There are bony prominences such as the greater and lesser trochanters, to which there are significant soft tissue attachments, muscles, tendons, ligaments, and so on. The vascular anatomy to the hip is very important for the interventions that we undertake. The blood supply to the hip is provided by the profunda femoris branch of the femoral artery, which in turn gives rise to the medial and lateral circumflex arteries, and they then supply the femoral head. And knowledge of this anatomy allows us to manipulate the femoral head, hopefully to good effect in reducing pain and improving outcomes for these patients. In terms of investigations, like all conditions, it's about taking a history and doing an examination. The typical pain that people describe specific to the hip is that C sign, one hand on the groin and one hand on the lateral hip. Deep-seated groin pain, lateral hip pain, occasionally radiating down the thigh as far as the knee. Interestingly, buttock pain is less a feature of hip joint pain, consisting of only 10% of pain of that origin. Buttock pain is more commonly from the back. Typically, the things to look for when you're examining someone's hip are their gait. Do they have an antalgic gait or a Trendelenburg gait, possibly a short leg gait? The Faber or flexion abduction external rotation test is less specific for hip pathology, but commonly done. The Fader or flexion adduction and internal rotation is more specific to impingement type pathologies. But really, you're looking for pain at extremes of range of motion, or as hip pathology progresses and patients develop more arthritic hips, then they're going to have reduced range of motion with pain at lower ranges of motion. A history of pediatric hip disease can be a hint that something may not be quite right with that hip. In terms of investigating these patients, really the preferred investigation is a plain film x-ray. And the AP pelvis is really the workhorse of what we're looking for. In younger patients, a lateral can also be of benefit, and the usefulness of an X-ray far outweighs that of an MRI. MRIs are commonly requested in younger people with hip problems, and really they're not that useful investigation for as a first line for assessing these patients. Now, an MR arthrogram can be a useful investigation for determining whether patients have significant intra-articular pathology, but really it's only part of the workup, and I would always look to the plain X-ray initially. In terms of the initial management of a younger person with hip pain, it's the same as with any musculoskeletal condition. It's rest, modify activities so you avoid those activities that cause pain. Ideally, reduce impact sports. These can contribute to increasing pain. Anti-inflammatory medication does have a significant role to play, assuming patients don't get significant GI side effects. Physio can have a role, but typically these patients tend to be quite fit, and maybe physio wouldn't be the first port of call. And in a certain patient cohort, weight reduction has a role to play, both in reducing their symptoms, but also reducing the complexity of surgery if and when it comes to it. In terms of pathology, I'm going to touch on developmental hip dysplasia, femoral acetabular impingement, particularly in relation to slipped upper femoral epiphysis and Perthes disease. Developmental hip dysplasia, everyone is familiar with it in terms of pediatrics. The baby's getting checked in the maternity hospitals and subsequently being treated in the pediatric hospitals. But really, silent dysplasia can present much later in life with hip pain, the diagnosis being made on hip X-ray. There is an incidence of 0.06 to 76 per thousand live births, depending on what you read. And it is more common in Ireland than in other jurisdictions. It tends to be more left and occasionally unilateral, more than bilateral. The risk factors for presentation in the pediatric sphere are breech, family history, ethnicity, gender, and apparently there is a seasonal variation. In terms of how you diagnose it, we look at X-ray parameters to determine whether the hip is appropriately covered. And those X-ray parameters include things like anterior and lateral center edge angle, sursal angle, lateral extrusion ratio, and we look for femoral neck anteversion. And these are also the markers that you try to improve. Now, again, to try and assess the joint, MR arthrogram may be useful to see if the patient has some degree of established arthritis prior to any intervention, but the X-ray makes the diagnosis. The workhorse for managing this condition in adulthood is the Ganz osteotomy or Bernese osteotomy or periacetabular osteotomy. These three terms are used interchangeably. And the gist of that surgery is the acetabulum is cut out of the pelvis by making a cut in the ischium up the posterior column to the ilium and cutting the pubis. And this allows manipulation of the acetabulum to cover the femur. So this is an example of left-sided hip dysplasia, and in this patient, they have an upturned sursal. They have some amount of early subchondral sclerosis with early cystic change. Their head is slightly uncovered. It's certainly on the milder end of things, but this patient presented with left-sided hip pain. And if they were to have any other intervention, the pain would persist. But this patient had a pelvic osteotomy, which subsequently resulted in good coverage of the hip and resolution of their pain. In terms of outcomes, Dr. Ganz is the person who's published the longest series of them, and they would report 80% 10-year survivorship, meaning 80% of patients get at least 10 years out of this osteotomy, and up to 60% 20-year survivorship. And that can make a big difference to people who are presenting in their 20s or 30s with hip pain, and you're trying to avoid doing a hip replacement. It means that they may get their hip replacement in their 40s or 50s, which will lead to a much better outcome. In terms of Perthes disease, these patients present with a much more significant femoral deformity, occasionally also with an acetabular deformity. The main issue being that they have a square block sitting in a round hole. So to address this, we typically employ a tool called surgical hip dislocation. And this is where the trochanter is cut off the femur to allow for dislocation of the hip while respecting the vascular supply to the femoral head. It allows for extensive resection of the abnormal bony anatomy at the front of the hip, and also addressing intra-articular pathology. And then the trochanter is able to be advanced to give a more normal shape hip. It doesn't give completely normal anatomy, but it does improve the shape of the hip and improve pain. Now, you can get carried away and you can do too much surgery. And it really is a balance between trying to improve this patient's quality of life and their pain without losing the run of ourselves. In relation to slipped upper femoral epiphysis, this is a condition of adolescence where the femoral neck slips on the head, despite the name saying it's a slipped capitofemoral epiphysis. It's really the head stays in the socket and more the neck shifts. And it's a very typical deformity which results in femoral acetabular impingement. There is a male preponderance. These patients tend to be somewhat overweight. It can be bilateral, and there's a risk of avascular necrosis at its initial presentation in adolescence. However, when these patients get older, they can present with anterior hip and groin pain in keeping with impingement. But the problem is both the retained screw in the femoral head-neck junction and also the bony abnormality of the femoral head. So this is a patient who presented in September of 2013, and you can see on the right-hand side, the more normal anatomy of the hip, and on the left-hand side, the protruding screw with the flat shoulder in keeping with femoral acetabular impingements. These patients can be treated either with by removing the screw and addressing the bony lesion, or they can have a femoral osteotomy to try and reshape the femoral head and prevent this impingement. This is an example of what these patients can look like in the postoperative period. And again, it has to be emphasized, these patients are not completely normal, but it does improve their outcome. Now, in terms of this surgery, again, they can have up to 80% 10-year survivorship with good functional outcome and pain relief. In terms of the diagnosis of idiopathic femoral acetabular impingement, this is a clinical condition where there is a bump or extra bone either on the femur or the acetabulum, and as a result, one bumps against the other, leading to damage of the acetabular labrum and possibly the underlying cartilage. Patients with this typically present with pain. Again, the diagnosis of the CAM lesion is usually made on a plain X-ray rather than on an MRI scan. And there's an example of a typical CAM lesion on an AP. It can further be delineated on a CT scan. And CT scanning can allow for assessment of the pre and post-operative deformity to assess whether we've achieved proper resection of the lesion. MR arthrogram is useful for diagnosing the intra-articular pathology, and the white arrow here demonstrates where the acetabular labrum is, with the white contrast going between the labrum and the bone. The treatment for this is typically hip arthroscopy, this being a day case procedure which we offer in Cappagh Hospital. And patients are placed on a table. Their hip is distracted out of the socket through small percutaneous incisions. Instruments such as on the left can be inserted into the joint to address the underlying pathology. These are some intraoperative photos showing you the type of view that you get. In the picture on the left, you can see the acetabulum in front. The labrum is between 11 and 6 o'clock, with the femoral head between 5 and 7 o'clock. And there is a tear of the acetabular labrum with some chondral delamination. The picture on the right shows a more degenerative labral tear with stranding of the acetabular labrum. Arthroscopy improves pain and improves hip scores with good patient satisfaction. It is generally a very safe procedure. The patients do best when they don't have any underlying chondral damage. Therefore, you don't tend to do them in patients once they start hitting their mid-40s or late 40s, as those patients typically have underlying chondral damage. And sometimes you have to do arthroplasty. Sometimes hip patients or patients with hip pain present with pathology that is not amenable to non-arthroplasty surgery. This is an example of a 13-year-old who had multiple surgeries trying to preserve her joint, and unfortunately she was left with an arthritic degenerative joint which required a hip replacement at the age of 14. And this provides good symptomatic pain relief. Unfortunately, it does have significant consequences for down the road, but the aim is to get her as normal as possible and live a pain-free life for as long as she can do. So ultimately, the aim of all of our interventions are to treat pain. How well they do is determined by the underlying chondral damage, and hopefully this leads to preservation of the hip and avoiding joint replacement for as long as possible. Thank you very much.